So now we're going to talk about non-respiratory movements. So these are not part of ventilation or breathing. So a sigh is a slow, deep inhale held and followed by a slow expiration. How a sigh is beneficial is that it reopens small clusters of alveoli that have collapsed because of the surface tension. So to break surface tension, we're going to make surfactant in those areas. A yawn is a larger sigh. It basically forces you to breathe in more than what you normally would. You inhale more. So when you're tired, again, if you have more air coming in, you have more pressure. So it's going to help minimize how many alveoli naturally collapse when you sleep. After you sleep, it's going to reopen those that collapsed. A sneeze is a deep inspiration followed by a large forceful expiration through the nose. Velocity, pretty crazy, can get up to 100 miles per hour. Why you would sneeze to clear foreign or irritating substances, typically within the nasal cavity or nasopharynx. A cough is similar to a sneeze, except when you initially breathe in, it's very small, or you might not do it at all, so it comes on a little more suddenly. Velocity is almost 500 miles per hour. So it helps to clear the larynx if you might have a piece of food or something like that that gets lodged. If it happened to go even deeper, the trachea, or even lower airways. Okay, so in this picture, we can talk about the different pressures that we have. So atmospheric pressure is the pressure that's in the air. So at sea level, that's going to be 760 millimeters of mercury. And as you see, it doesn't matter if you're not breathing in or breathing out, that's going to stay the same. The intrapulmonary pressure is what is inside the lungs, specifically the tiny little air sacs in the lungs. So when you're not breathing in or out between breaths, notice that it's the exact same as the atmospheric pressure. We look between breaths, the intrapleural pressure. This is the pressure within the pleural cavity, which remember is that small space between your visceral and parietal pleura. That's going to be slightly lower than the intrapulmonary, so it creates kind of a suctioning effect that helps keep the lungs inflated. So as you breathe in, what you notice is the intrapulmonary pressure has dropped because muscles have allowed us to expand the thoracic cavity, so we've increased in volume. Remember, when you increase in volume, it's going to have the opposite effect on pressure. So we've decreased pressure, as we see here. Notice that to make sure the lungs stay inflated, we've also decreased the intrapleural pressure. Naturally, as the parietal pleura gets pulled, as the diaphragm and external intercostals contract, it's going to allow a little bit more space between the parietal and visceral pleura, and that's why you have that drop in pressure. The key to see here is that the pressure inside of the lungs is less than the atmospheric pressure. So because of the pressure gradient, air is going to move from where there's a higher pressure to lower pressure. So that's why it moves into the lungs. So as air moves into the lungs, you are adding gas molecules, which causes an increase in the pressure inside of the lungs. So now our pressure inside is greater than out. The diaphragm and external intercostal muscles will relax, which will increase the intrapleural pressure and, of course, force air out. Okay, so if we're looking at the intrapleural pressure in cases where there's damage, sometimes the pressure that is outside of the lungs can actually become greater or the same, that 760 millimeters of mercury pressure. When this happens, it's going to basically, the lung's going to collapse because you don't have that suctioning effect that forces the lung to want to stay open. Of course, in this case, a knife would do that, but any type of trauma that potentially could break a rib, ribs can act like that knife and pierce through, breaking that parietal pleura, and that can greatly increase the interpleural pressure. So when something pierces that cavity, two different things can happen. Fluid can build up in the space. If they're bleeding, you could basically have blood that fills up in this area, forces the lung to collapse. Or if you're not potentially bleeding, but the opening allows air to come in, as air enters, that will force the lung to collapse. So when it's because too much fluid, we call that pleural effusion. And when it's because too much air, we refer to that as a pneumothorax. And then blood, if blood enters, it's a hemothorax. Pleural effusion, one cause of that could be if you have a lot of increased inflammation, naturally you're going to make more serous fluid because its function is to reduce friction. So pulmonary ventilation or breathing basically boils down to your pressure and volume relationship and the fact that air will always move from high pressure to low pressure. And of course, pressure and volume have an inverse relationship. So if volume is increased, pressure will be decreased, and obviously vice versa. So between breaths, no air movement is occurring because the pressure inside of the lungs, the intrapulmonary pressure, and the atmospheric pressure are equal. Muscles that will cause inspiration will then contract, which would include your diaphragm and the external intercostals. That increases the volume. So now the pressure has decreased. So the pressure, intrapulmonary pressure, is now less than the atmospheric pressure. And that is why we actually inhale and air moves inward. It's going from high pressure to low pressure. As we add air molecules into the lungs, we've increased the pressure inside of the lungs. The muscles that were causing the expansion relax, which increases the pressure even more. So now we have a higher pressure inside of the lungs than we do in the atmosphere. And that is why air is going to move outward. So pulmonary ventilation isn't 100% effective. There are three factors that can decrease the pulmonary ventilation. So the first is airway resistance. So anything that blocks, impedes airflow through the respiratory tract. This could be a tumor, it could be mucus, it could be blood. Alveolar surface tension should be reduced by the surfactant that is made. If not enough surfactant is made, then the alveoli are not going to have that nice open look, and naturally, because of the polar properties of water, they're going to pull towards one another, collapsing it, which decreases the amount of surface area that gas exchange can occur. And the third is pulmonary compliance. This is basically how easily can the lungs, and what actually allows the lungs to expand, your basically thoracic cage to stretch, to increase in volume. Typically what you see is as you age, pulmonary compliance will decrease. First of all, the costal cartilage that is found between your ribs and the sternum slowly ossifies. It starts to do this around age 30. So that will decrease the flexibility of the chest. Also, typically as people age, they do not work out as much, so they do not require heavy breathing. So if you quit inhaling so deeply and exhaling, you lose that muscle strength. So then you are unable to actually inflate the lungs as much to increase the thoracic volume, which of course inflates the lungs. Or if you have bruising of the ribs, anything that would basically affect your ability to be able to increase that thoracic volume. Okay, and we will discuss each one of these factors in more in detail. So one of the factors, airway resistance, the way that we can of course control that is by if the bronchioles are constricted or dilated. So if they're dilation, that means that the smooth muscles will be relaxed, which allows the bronchial diameter to open up, which would of course increase the airway, which would decrease the resistance, making it easier for air to get to the alveoli. During contraction, that would decrease the diameter, which would increase the resistance and decrease the amount of air that could reach your alveoli. Sympathetic response, such as exercising, removing yourself from a fearful situation, you need more oxygen. So that means you would increase the diameter to decrease the resistance, which would allow more oxygen to get to the lungs. Parasympathetic mode, you do not need as much oxygen because your cells are not metabolizing at as high a rate. So you will actually have constriction of the bronchioles. This is kind of a cool picture. This is a actual tissue slide. You can see the terminal bronchiole, the edges of it, and then this would be the smooth muscle that's banded around that controls the diameter. Okay, so again, your alveoli like to be this nice and open look to them. Naturally, because of the water molecules, they're polar, so they're going to be attracted to one another. So we have surfactant that comes in here and it basically coats over this water molecules that you have, so you do not have them pulling towards one another, and your alveoli can stay open even in expiration. Of course, surface tension is going to be the greatest in expiration, so they're going to close up a little bit because you don't have the force of air coming in, which helps force them open. If you remember back in an anatomy slide, when you're actually looking at an alveolus, it has these elastic fibers that are around it. Remember, naturally elastic fibers will recoil when they're not being stretched, which would be when pressure's low when you're exhaling, or towards the end of expiration, technically. So if a person is unable to make surfactant, then you have this surface tension with nothing to break it down. Okay, act like that detergent and break it down. So the alveoli will collapse during expiration, and we call this atelectasis. So without surfactant, as we see in this picture here, naturally the water molecules would want to pull towards one another. With the surfactant, we do not have surface tension, so you have this nice open alveoli. And basically, nice open alveoli means you have more surface area. The greater the surface area, the greater gas exchange, bringing oxygen into the blood. Pulmonary compliance is the effectiveness of gas to be exchanged. So there are a few different factors that apply here. Ability of the lungs and chest wall to stretch. I mentioned a few of these things that can happen. So as we were just talking about alveolar surface tension, if you have that happening, alveoli are collapsed, then you're going to have an decrease the compliance. The compliance is the ability to stretch. Surfactant, of course, breaks the surface tension, increasing the ability for the alveoli to be larger, which increases gas exchange. The lungs are surrounded with elastic tissue, all of the alveoli. Elastic tissue naturally has a lot of stretch to it. So the more stretch, the more compliance, and the easier for gas exchange. As we age, elastic tissue becomes less stretchable. And then, of course, as we already mentioned, the ability for the chest wall to move. Of course, it's at a high compliance when you're breathing in, and the stronger the external intercostals and the more you can contract the diaphragm, the more you can move the thoracic cage and the greater the compliance. So once again, if compliance decreases, then lungs are not able to expand and pulmonary ventilation and the exchange of gases therefore will be decreased. So as I mentioned, not being able to make enough surfactant would increase the amount of surface tension, the collapse of the alveoli, and therefore the ability of gases to be exchanged or compliance would be decreased. So because the infant doesn't have to have gas exchange in utero, surfactant's not produced in high enough amounts until the last 10 to 12 weeks in the womb. So any baby that's born early during this last 10 to 12 weeks is not going to have enough surfactant. Naturally then, they're going to have the surface tension. The alveoli are going to be closed, which means they're going to have a reduced amount of gas exchange. So they're going to have poor oxygen carrying abilities to their tissues. And we call this respiratory distress syndrome. So risk factors that would increase your likelihood or a baby's likelihood of getting this. Of course, if they're born premature, so their lungs haven't had time, the alveolar type 2 cells haven't developed and had time to make surfactant. Male gender, it's actually a study that shows that basically male gender having testosterone slows down the surfactant producing capability, and males are about 2.5 times more likely to have this RDS than a female. If the mom has diabetes while she's pregnant, if there's a family history of RDS, or if the baby is born through cesarean. If they know there are going to be complications and a baby needs to be born early, they can give the mom steroids, and that will help increase the surfactant production. So treatment, they basically give you synthetic surfactant by breathing in. It's basically a breathing treatment. We call CPAP, positive airway pressure. This provides just enough pressure that the alveoli won't collapse, and so you'll have that good amount of surface area for gas exchange. And if it's really premature and the RDS is very severe, they'll do mechanical ventilation, so a machine's breathing for the infant. So an easy way to be able to see if a person might be having any type of respiratory problem is to see if their volumes, the amount of air that they're able to breathe in, out, etc., are what they should be. So a tool we use to assess this is called a spirometer. And you can get 3 volumes by using a spirometer. So tidal volume, which is the amount of air that can normally be breathed in and out at rest. Inspiratory reserve volume is the additional amount of air that can be breathed in over normal. And expiratory reserve volume is the additional amount of air that can be breathed out after normal breath. I don't necessarily want you to know all these numbers. Tidal volume, I do want you to know. Tidal volume is 500 milliliters in healthy adults. It doesn't matter if it's a male or a female. And again, this is normal, quiet ventilation. So this is not you trying to take deep breaths or breathing really rapidly during exercise. Okay, so you can take 500 milliliters, and that's per breath. Okay, that's the amount of air that's moving in and out as you normally breathe. And you can multiply it by how many breaths per minute, which on average would be 12. So breaths are going to cancel out, and you're left with how much air per minute we move, which in the average healthy adult, this is going to be about 6 liters of air a minute. And again, this is normal, quiet ventilation. However, of this 500 milliliters that is moved in and out of the lungs during ventilation, only 350 of this is actually available for gas exchange. So 150 milliliters is in anatomical dead space. It's in space where gas exchange cannot occur. So anywhere where alveoli are not. So where alveoli are, where gas can occur, that's the respiratory zone. Remember, that begins with the respiratory bronchiole. So starting with any other respiratory structure, the last one being the terminal bronchiole, that would be conducting zone, and that's where those 150 milliliters of air can be. So alveolar ventilation rate is the amount of air that actually reaches the alveoli. So not that's part of anatomical dead space per minute. So this would be your 350 times 12. So that's about 4.2 liters per minute is actually able to be exchanged across our respiratory membrane. So capacities can be calculated by adding volumes together. So vital capacity is how much air can you actually move in and out of the lungs. So it's the amount that you can move during normal breathing, plus the additional that can be breathed in during inspiration, the inspiratory reserve volume, plus the additional that can be breathed out after a person has breathed out normally. So total lung capacity includes all of these values that can actually be moved in and out of the lungs by that which always remains. So RV is the residual volume. This is the amount that stays in the conducting zones, basically the anatomical dead space, no matter what you do. So all of that's going to equal the total lung capacity. So basically the total amount of air that can be held within the respiratory system. So I want you to know what each one of these volumes or capacities represents and how to calculate it, if that's possible. And I do want you to know tidal volume being 500 milliliters. So this just basically graphically shows what we were talking about. So again, tidal volume is how much that you're going to be moved in the respiratory system, breathing in and out during normal breathing. Of course, after you breathe at a normal amount, you can take in quite a bit extra. So that's your IRV. After you normally breathe out, there's extra you can still exhale. So again, all of these together, the additional amount you can breathe in, the additional amount you can breathe out, plus the normal amount, that is the vital capacity. And then of course, residual volume, this is the amount that remains, a little over 1,000 milliliters. The only way you'd be able to get that out would be to stomp on the lungs and the respiratory system. Really the only other thing you can note that obviously for breathing in, we can breathe in a lot more additionally that you can breathe out. Of course, that's a benefit to us when we're in sympathetic mode. And these volumes are going to be less in females than males just because typically females are smaller in size. Therefore, the volume of the thoracic cage cannot get as large. So review, a mechanical ventilator is something that aids someone that cannot breathe on their own. So directly, that's going to help air move in and air move out. And that is pulmonary ventilation. External respiration is the movement of gases that occurs between the alveoli and the pulmonary capillary beds. Internal is between tissue capillary beds and the interstitial fluid, which of course a machine that helps you do that is not going to make sure that gas actually diffuses, so it would not be part of external respiration and of course not part of internal. So which of the following muscles would contract during quiet exhalation? Quiet exhalation does not require any contraction of muscles. Naturally, the recoiling capability of the lungs forces air out. Now, if the question were changed to during exercise or not quiet, the muscles which can force more air out, which basically creates the ERV, the expiratory reserve volume, would be the internal intercostals and abdominal muscles. They could further depress the rib cage. Air moves into the lungs during inspiration due to the force of atmospheric pressure. Atmospheric pressure is greater than the intrapulmonary pressure. And we know that air moves from high to low pressure, so naturally it's going to move in. It's a difference in pressure which creates the force, the movement of air. So the atmospheric pressure is greater than the pressure in the lungs because the diaphragm contracted and the external intercostals contracted, but that's not what actually provides the force. Air is forced out of the lungs during normal expiration. So this is an additional, and I already said this, but because of the elastic recoil abilities of the alveoli, it forces air out, it forces a small space. The smaller the volume, that increases the pressure. So now you have a greater pressure inside of the lungs, which of course is why you exhale. And then Boyle's law explains that pressure and volume have an inverse relationship. So the greater the volume or the space in the thoracic cage, the less the pressure. When the volume gets smaller during expiration, then the pressure increases, which of course is why air will move out.